Before we start, I think in accordance to the city and our Health Commission resolution, Mr. Morwich will read the acknowledgement of land statement. Right.
Yes. The San Francisco Health Commission acknowledges that we are on unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for the peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you very much, Mark. And we'll proceed then with our next item, please.
I'm actually going to call roll quickly, Commissioner Chow, just to make sure that we're in alignment with what we need to do for our meeting. So I'll start with you, Commissioner Chow.
Okay, thank you. I'm here. That was the next item.
Oh, I'm sorry. Commissioner Green?
Present.
And Commissioner Christian?
Present.
Great. Thank you.
Okay, and now we'll go on to the second item.
The approval of the minutes of the July 27, 2021 JCC meeting. I'll note that I sent around corrected minutes. I had incorrectly noted that Commissioner Christian was absent. She came a few minutes late, and I apologize to her for that omission.
Thank you. Is there a motion for acceptance of the minutes?
So moved. Second.
I heard a move and second. Let's proceed. Are there any public comments on the minutes?
On the comment line, if you'd like to comment on item 2, please press *3 to raise your hand so we can acknowledge you. *3. There are no hands, commissioners.
Okay, so then let's proceed with the vote.
Sure. Commissioner Christian?
Yes.
Commissioner Green?
Yes.
And Commissioner Chow?
Yes.
All right, the minutes have been approved.
Okay, our next item, please.
Yes, item 3 is the Regulatory Affairs Report.
Hi, good afternoon, Commissioners. Thank you for giving me time on the agenda to bring you up to date with regulatory affairs. As you can see on the report, of note, we still have 3 outstanding surveys that we anticipate. To add to that, we are expecting a visit next week to our office-based opioid treatment program from the Department of Healthcare Services in California, and that's their annual review. We generally do very well in that review. But they will be visiting us next week, and the week after Labor Day week, we can expect CDPH to come and review our radiology and mammography from the radiology branch of CDPH. So there's some upcoming surveys. I want to really celebrate our completed Medicare deficiency revisit, which happened just 2 weeks ago now, where we were found to be fully compliant with all aspects of the findings that were initially out of compliance with CMS regulations. And I would just really want to just take a moment to reflect on the exit survey that the surveyor gave us, where she used words like perfect and fantastic. The thing that really stayed with me is she talked about how surveyors, who are predominantly clinicians who have moved on to a different stage in their careers, live vicariously through the organizations they survey. And she stated that she felt fulfilled on exiting Zsfg that day. And it just made my heart swell with pride. And I just really want to celebrate that. Looking at the rest of the regulatory affairs report, there's still a lot of open site visits, but of note, 5 of our open site visits have now been referred to the Joint Commission. So what that means is that the local CDPH office let us know that we need to self-report those as patient safety events to the Joint Commission. Once the Joint Commission receive those and triage them, then they ask us to give them a summary of our investigation and any performance improvement that happened following those events. So we're working with the Joint Commission right now to get those all put into the system, and then we'll follow up on those. So that's going to reduce some of that backlog that CDPH are also working on. And then the other piece is in the plans of correction, you'll see 2 privacy breaches. You also see those 2 privacy breaches appear in the new facility reported incidents. We put them in there to bring them back up to the top of everyone's radar. These will have appeared on a regulatory affairs report back in 2015 and 2016, but they're not current on the report. So we included them at the end of the report, but we actually submitted plans of correction this month too to address them. They were late to follow up on those 2 events, but we were able to describe the performance improvement and the follow-up that was done in real time back in 2016 around these 2 events. So they appear in 2 places in this report, but it was really just to close the loop. And then I think out of those facility reported incidents, there's 7 in the new section. 2 of them we've already discussed, and out of the other 5, some work that we're doing with the operation side and risk management to investigate those events. And there was a couple of really unusual events that around gastric perforation. One was very specifically around a G-tube, and one was an iatrogenic perforation that occurred, and it was concurrent to a patient's intubation. We were unable to completely rule out one as a causation to the other. So in a effort of transparency and an effort to really focus on how our QAPI process picked up these events, followed up on them, and have investigated and done performance improvement, we've included that in the report as well. Are there any questions regarding the regulatory affairs report this month?
So I know Commissioner Green had some questions. I wonder if she had any follow-up to that? Or...
Oh, no, you've really kindly answered the questions I had. Thank you.
Thank you. Commissioner Christian, any questions?
No questions. Just want to offer my congratulations, though, on that excellent report that you gave us at the beginning. It must feel amazing to you. So well done. Congratulations.
Thank you.
And I'm truly taking credit for the work that the nursing and the anesthesia departments did to correct those deficiencies. So I can't claim the credit for it. I can just bask in the adulation of the surveyor.
We'll enjoy that.
Thank you.
Well, clearly, after your note, we did send also, and hope you conveyed our congratulations for the excellent follow-up survey that you all experienced, and to see the staff was really committed to doing these and embracing them as a performance improvement rather than simply as a regulatory issue. So that was very nice to hear. I was wondering what criteria the state uses to refer to the Joint Commission. Is there anything transparent to you about that?
What a great question. And I have actually asked that question directly of the state. And there are not clear criteria. The district supervisors triage each event as it comes in. So I think there's a lot of subjectivity to how they triage them. They don't have clear set objective criteria. So sometimes it really is if something's considered low risk, but some of that consideration of low risk may be in comparison to other events that have been reported or being investigated around the same time. So unfortunately, there is not objective criteria. We're at the whim of CDPH.
Okay, I guess finally on your facility report, and you've pointed out the unusual occurrences in regards to the gastric perforation. Are you then in the course of yourselves independently reviewing those? And
yes, we are correct. We are reviewing those events independently. Risk management's going through that process.
Okay, and I guess finally you did mention several surveys pending, but they weren't actually on the list. So Is there a reason that they weren't, or are they just sort of surprise surveys?
Clearly, just to completely an omission on my part. As I was putting the report together, I had a mental blank on those two surveys. We did know about them. We were informed by both the regulatory bodies and the departments involved in good time, and it's totally on me for their omission.
No, that's okay. And thank you. I just wondering whether it was a surprise visit or certainly with all the work that you all have been doing there and the stresses, that's understandable. So thank you, and we'll look forward to the survey results.
Thank you.
Thank you. Are there any other questions or comments by either the public or by our other participants?
I'm going to check public comment real quickly. Folks on the line, if you'd like to make comment on item 3, the regulatory affairs report, please press *3 to get recognized. *3. No hands up, Commissioner.
Okay, thank you. I don't see any others on the listing I have here either. So in that case, let us proceed on to the next item, please.
Sure. Item 4 is the Equity A3 presentation.
Good afternoon, Commissioners. Can you hear me okay?
Yes.
Great. Excellent. I am very privileged this afternoon to present our work on equity. I'll be doing an introduction, and my colleague Andrea Turner will be going through the work as well. So let's start. This is our True North Triangle. I think we have at least one of these every single meeting. Just to remind us of what our true north is, and that equity actually figures quite prominently here in our triangle. And as we think about equity, even though it occupies that lower left corner of the triangle, what our real aspiration is that equity pervades all of the work that we do in all of our true north goals, and the Zsfg way, which is the way we lead, the way we align and improve in the organization. Next slide. What we hope to talk with you about this afternoon and have some discussion about is where we are currently in our equity journey at Zsfg, and specifically what are our targets for the coming year and beyond. This is the view of our A3, just so you know that it's there. Of course, we won't go through this slide in detail because it's not really easily visible. But it does give you a sense that we've thought about this work very intensively, and we have a robust set of countermeasures to talk with you about. Next slide. This is not the beginning of our journey, and this is something that I'm actually quite proud of. Equity and structural racism and health inequities have definitely become a much more discussed topic over the past couple of years with all that we've been through with COVID and George Floyd's murder and other events that have really heightened this topic. But we've been at this really since I got here, starting in 2016. And in 2017, we established equity as one of the True North goals on our triangle, established an equity council, and started looking initially at our equity data to start with our real and Zsfg data, that is the race, ethnicity, and language, and sexual orientation and gender identity. And the reason we started in that place is because we didn't really have good data or reliable data. And we all know that without good data, we don't know where we are, and we certainly don't know how we can improve. So that was a very important starting point for us. And we also started working equity through PIPs, and you're going to hear a lot about the PIPs committee today and the very robust and extensive work that we're doing to identify and eliminate health disparities through the PIPs committee. I won't go through all of this in detail, but you can see in 2018 we actually did an equity survey that was very eye-opening for us. This was a survey that really looked along the GARE lines and the GARE standards about, you know, how well do we perform as an organization in equity, in the area of diversity, equity, inclusion. And what we found when we did that survey was the answer was not well. First of all, we didn't rate well along the scale, the GARE scale, which is a Likert scale, a 5-point scale. We ended up rating ourselves as a 2, and we saw pretty distinct disparities between the different racial and ethnic groups. So that set a course for us and made us realize the types of work we needed to do. We started with the equity newsletter and equity town halls, which were a very great way of getting information both to our organization and from. In 2019, we hired a director of equity, Ontang Dal Shah. You probably remember her. She has since left us, and we are in the process of recruiting her replacement. But Andrea Turner, our Chief Operating Officer, has taken on that mantle and done an incredibly wonderful job with this, and you'll hear from her more later. We proceeded on our journey by establishing equity champions, then in 2020 establishing PIPS drivers, and some of the other work that we'll talk about in more detail, both for 2020 and 2021. Next slide. As we were doing this work, of course, with the A3, one of the most important parts of the A3 is the problem statement. And this is the problem statement that we define for ourselves, and that is that structural racism is a system in which policies, practices, and culture reinforce racial inequity. And without eliminating structural racism at ZSFG, we cannot address health inequities among our patients, and we cannot address disparities in our staff and provider experiences at ZSFG. So this gives you a sense of what it is we're aiming at. We're really looking at the foundation of the work that we do, the foundation of our policies, practices, and culture in order to address the disparities that we see and really establish goals and targets for ourselves. Next slide. So at this point, I'm going to turn it over to my colleague and the leader for this work at ZSFG, Andrea Turner. Thank you, Andrea.
Thanks, Dr. Ehrlich. Good afternoon, Health Commissioners. It is both my privilege and honor to present to you today on this very important topic. My name is Andrea Turner, and I am the Chief Operating Officer here at General Hospital. Under the leadership of Dr. Ehrlich and Dr. Bennett, I am proud to say the work evidenced in these slides highlights some of the incredible work we've been doing at ZSFG. So in response to the problem statement, we looked at an organizational approach, and we reached out to some of our partners, the PIPS committee, as well as KPO. And the PIPS committee, the Performance Improvement Patient Safety Committee, is chaired by Will Hewen and now Adrian Smith. Here, our organization's strategic quotient is to have 50% of departments with an equity driver. And every department is to present their equity metrics annually at PIPS. KPO, Kaizen Performance Office, which is directed by Jenna Belinsky, is to teach and coach thinking, A3 thinking, in finding, owning, and implementing solutions. One method is the use of the daily management system, in which daily huddles are performed that highlight opportunities and, when appropriate, PDSA, Plan, Do, Study, Act, as well as recognition to reinforce the good work and to build partnerships in finding solutions for common problems. Next slide, please. The next 3 slides are examples of the equity work being done. The first slide highlights equity work that began in 2017 through 2020, through 2020 in the following departments. So here you could see perinatal, OBGYN focused on breastfeeding, pediatrics focused on Black African American childhood immunizations, psychiatry focused on seclusion or restraints and PS readmit by race, peri-op focused on OR wait times by race, cath lab focused on door to balloon times by race, ethnicity, and language. Next slide, please. On this slide, it shows 3 departments: oral surgery, rehab, and pathology. Oral surgery focused on no-show rates stratified by race and ethnicity. Rehab focused on no-show rates and percentage of inpatient rehab orders that resulted in an evaluation stratified by equity data. And pathology focused on use of lidocaine discriminately may be due to unconscious or implicit bias. Next slide, please. The third slide highlights the work being done at the Family Health Center, in which they have categorized in 3 buckets: network, clinic, and patients. And here they're talking about in network, they're looking at hypertension, equity work group formation, and establishing a food pharmacy and blood work or blood pressure visits. This work, I think, with the Family Health Center has been highlighted in many venues, to include the Equity Council, where we've talked about how the Family Health Center has rolled out these different plans and how they've implemented the equity strategies. Next slide, please. Our target: increase the percentage of departments with equity drivers and countermeasures by Q4 2021 from 30% to 50%. And so we did an analysis of potential barriers to achieving the target. We looked at communication, leadership management, hiring, recruitment, and retention, staff competencies, organizational commitment, community, and staff engagement. Sorry, can we go to the next slide, please? Thank you. Under communication as a barrier, we looked at the limited forum for staff to participate in equity work at the department level, leadership or management, unclear accountability structure for disparity in health outcomes and workforce development. And under hiring, recruitment, and retention, we looked at equity as not a key competency in recruitment and promotion. Staff competencies in equitable access to equity training, organizational commitment, not all departments have clear equity metrics, and community and staff engagement. We looked at the limited venue to hear from community and staff from underrepresented communities. Next slide, please. So in this, looked at revising the PIP standard work to ensure all departments had an equity metric. And we're continuing with that. So the status update is ongoing. Secondly, we looked at the equity survey, as Dr. Ehrlich mentioned, and we used the equity surveys to learn, or survey to learn, the areas of opportunity. This will be done on a biannual basis, and that will be ongoing. We also hired a director of equity, and now that An has departed, we're actually looking to hire someone to fulfill those shoes. We also have the Equity Seed program to support equity champions, managers in the creation of additional venues of communication about equity at the department level. And this actually was completed under An in October of 2020. The Respect Policy, which is a tool to address workplace culture and convey managers' responsibility to maintain a positive workplace culture for all, that's pending. We're still working with the HR as to implementing the Respect Policy. Next slide, please. And number 7, the pop-up lounge, to reboot the equity pop-up lounges. This actually got completed in September of 2019, but due to COVID, we actually stopped the pop-up lounges, so we haven't been able to meet with the team together, but it's being actually worked on to start doing it over Zoom or WebEx. So that is actually ongoing. And the equity module at new employee orientation actually got completed this year. And I want to just highlight that Kayla Gardner did a great job putting that together. So that was completed in February of 2021. Next slide, please. So this is a slide that highlights some of our equity subcouncils. And in the top left-hand corner, I want to make sure I get this right. In the top left-hand corner, this is radiology. And in the bottom right-hand corner, it's 4M. And I believe equity, the driver here for radiology is they're looking at patients that, female patients, Black, African, Brown, and Asian female patients pertaining to breast health. And so they're focusing on that, while 4M is looking at staff communication, making sure that staff is able to communicate with a shared understanding of what respectful communication looks like. Next slide, please. This is the Equity Council. There are many more participants on the Equity Council. Unfortunately, these were the pictures that I was able to get at the time. But as you can see, everybody is smiling. They enjoy the work. So this is amazing work, and they feel the same way. Next slide, please. So achievements. This is amazing. In the short space of time, like Dr. Ehrlich said, this work actually started in 2016 and 2017 till now, and we have been able to do amazing work. Here, we've surpassed a HOSHN strategic goal of 50% of Zsfg departments with an equity metric to a current 58% as of yesterday. Departments now have an equity metric, so that's to be celebrated. We have a strong alignment with the Racial Equity Action Plan, and we've secured the Director of Equity and Inclusion with funding for an equity department. I want to give a shout out to Jennifer Boffey for supporting that. And more than 12 departments now have equity sub-councils. When we started, we only had 5. So we're at 12 now. Next slide, please. This is just an example of our REAP assessment, and we are moving in the right direction. Here, our score is 68%. Next slide, please. Our next steps here is to hire the Director of Equity and Inclusion, build the Zsfg Department of Equity and Inclusion, increase our target from 50% of all departments with an equity driver to 65%, and implement the respect policy. Next slide, please. Thank you. What questions do you all have?
Mark, do we have any public comment?
Folks on the line, if you'd like to make comment on this item, which is item 4, please press *3 to raise your hand so we can acknowledge you. *3. I don't see any hands, commissioners.
Okay, thank you. Commissioners, comments in regards to these this very comprehensive presentation of the last, well, I would say, what, 1, 2, 3, 4, just about 5 years of work that Dr. Ehrlich has described for us. So I know that Commissioner Green had a number of questions, and I wonder if she has any follow-up questions in regards to the explanations that have been provided in regards to the presentation.
Well, first of all, thank you for the not only the written responses, but I think it's remarkable the topics that have been so thoughtfully chosen as strategy goals among the different groups. I mean, just knowing about the mammograms, for example, which is a huge issue in the BAA community, given that women tend to get more triple negative breast cancers. And so, I mean, I just see it's more thoughtful, and hearing the detail today has been really very helpful. And I just would applaud you for the amount of detail and work that has gone into this, and how much progress you've made in such a short period of time with the pandemic as a backdrop. It's quite incredible. I guess my curiosity is, if we started in 2016, as you look at your next steps, I mean, maybe I missed it, but do you have a sense of timetable for when some of these steps might be accomplished? And also, are they one leads to the next and to the next? In other words, would a respect policy be implemented while the department is being built? So do these arrows mean one follows the other, or will they happen coincidentally?
Thank you for that question, Commissioner. So we're going to be hiring, hopefully in the next 3 weeks, for the Director of Equity and Inclusion. I'm in the process of putting a peer panel together. So as soon as we get that together, we should be moving right along in getting that individual in that position. As far as the Equity Department, we wanted to have the director on board to help to build that. And so that would be the next step. And then, of course, with the work that is being done in that department, it would drive the increase in the target from 50% to the 65%. So that will be certainly a goal for that person to work alongside with PIPs and all the different departments to move that that goal along. And then, of course, implementing the respect policy is something that we need to ensure that is actually happening. And so we would be looking for more partners to ensure that that's happening and that it's being socialized well, as for all.
Do you have a sense of when, I mean, hires can sometimes take some time, and obviously building departments do as well. Do you have any target timeline?
Yes. Well, I wish HR was on the line, but I have a target. So hopefully we would get the person in by the end of September. That is of course, doing this. But I think, everyone, all my partners that we've been working with, they understand the need and how important this is. So I'm hoping that that will start very soon.
Excellent. Well, that was sooner than I thought you'd say, so that's great. Great answer. Thank you.
Thank you.
So I can't actually see, but I'll see if Commissioner Christian has any comments in regards to the presentation.
I actually do. Thank you so much for this presentation. As Dr. Ehrlich was saying, this has clearly been going on for a while, and it's really encouraging to see how deep and thoughtful the work is. And actually, a question was sparked in my mind by a couple of things, but on, I think it's slide number 9, the examples of PIPS equity drivers. And the pathology driver I thought was really interesting and made me think about whether it's been done or is being done, or is it possible to use the driver of pain medication generally, the offering of pain medication to patients depending on an analysis, depending on their ethnicity or race or any other category that you would use, because I know that that is something that has been known to be a disparity in the medical field generally, in hospitals, and people, Black African American people specifically, thought to be less in need of pain medication and able to and have a higher pain threshold. Do you have any information about that right now, or any thoughts about how that might be, whether it's feasible to look at that across the board?
Andrea, I can take this one. I know I can't remember which department it was, but it was either orthopedics or the emergency department looked at the use of pain medications for long bone pain and fracture. So I know that there are other departments that have been working on this topic. The PIPS work, remember, is we create the structure for and the coaching mechanism for them to choose metrics, but it's really a bottom-up approach, which is great because it allows the different areas and departments to choose what areas they feel are most important to them. We certainly have the ability to department-wide or Zuckerberg-specific analyses of use of pain medications by race, ethnicity, and language. It's a different kind of analysis and a different kind of approach if we look organization-wide, but I believe using the electronic health record, it would be possible.
I don't know whether it's something that internally it has come up among staff and doctors and people at all levels of staff, but certainly it's something that's being thought about and talked about in the public realm.
Yeah, absolutely. And that's why I gave the example of long bone pain, because I know that it's come up in other departments. Andrea, I don't know if you're aware of any other departments who are looking at the pain issue.
I do. So I know anesthesia also did that. Dr. Wong did that. And I know Mark Wilson, Dr. Wilson for IR is also doing that and looking at it. So yes.
Could you let the commissioner know what IR stands for, Andrea?
Oh, interventional radiology.
Thank you.
Thanks.
Thank you.
We can get back to you with a more comprehensive look at which departments are looking at this and what they've found.
Thank you. It would certainly be of interest, but it's not anything I would, push you to, push to the top of your agenda. But it's, the question was sparked in my mind.
Well, I did. I see Dr. Huon has his hand up. You see, once in a while I'll see these. But before we get to him, I did want to follow up also on Commissioner Christian's point, knowing that, of course, bottom up and in the work of the various divisions and departments, they identifying the disparities as they wish and find most helpful in their own organizations is probably very useful. But I think we've also been pointing out here that there might be some overarching issues that the hospital should look at, possibly this idea of looking at the administration of pain medicines and so somewhere I think as we mature this process, that might be something that then says it's not all bottom up, but there are some overarching issues that the organization also would like different departments to work on if they actually infuse that. And I don't want to, take away from the bottom up, which of course is very important, but I think we shouldn't ignore that there may be organizational issues. And
I think you'll see that in our next presentation, Dr. Chow.
Okay, good.
Workplace violence for
So,
sure.
Dr. Huon, I think you may have some comments for us.
You know what, I'm not surprised Susan and Andrea mostly covered the ones that were in our heads. The type of anesthesia provided in joint surgeries and the work for the long bone fractures. I'm impressed, Susan. That was like 3 or 4 years ago. You remember that? So yeah, longer amongst our Black African American patients, more time to getting their pain medications, but that they were able to resolve that actually by shining a light on that. The other side of it, there's a fair amount of work looking at opioid prescribing and over prescribing and under prescribing. As you can imagine, that's a double-edged sword there. So thinking about the right amount, and we just talked today. I think Leslie's on the call, or we talked with nursing administration this today, talking about whether the pain committee thinks there's opportunities to leverage EPIC specifically there. As you know, pain is a challenging area and worth some discovery. The data around pain is even harder, but I think the team was interested in looking into it.
Thank you. I had an additional comment which I thought I would express here, that I think this program that you all have is certainly one that's focusing on the health disparities and the inequities coming from that, which I'm really pleased the hospital has taken on. In addition, obviously, to the workforce disparity that definitely Dr. Bennett has been working on, and I think Dr. Bennett's been trying to incorporate both workforce and the racial equity. does the committee then also, or how does the committee, I guess, participate in the workforce question? Because almost all of these are focused on, patient health disparities.
You want me to take that, Susan?
Yeah, I think Dr. Chow, I'll just introduce and then Andrea can go into more details. That was exactly why we wanted to show you the REAP self-assessment that we did, because we very much, our work is very much aligned with the work that's going on department-wide. And that even though here we focus mostly on the PIPS work that we're doing in order to reduce health disparities, we are also working with Dr. Bennett and have achieved 68 percentage points in that REAP assessment. So I'll let Andrea speak more about that because she really straddles the work in both of these areas.
Thank you. So to answer Dr. Chow's question, I want to say that our lens is not just about the disparities like you mentioned amongst our patients. It's actually also for staff and looking at how we help staff. So if you look at our countermeasures, it's also an alignment with the REAP. So the countermeasures of having opportunities for Black, African American, and Latinx to be mentored and things of that nature. So there is a strong focus on our workforce as well. Dr. Bennett, under her leadership as well, we've been working to help our team. And also, I think we've done a good job aligning with the HR department in that respect as well. So there is that partnership as well to get assistance in that way. But it is most definitely something that we are focused on with our staff and our workforce and giving them opportunities to grow and also to be a part of the work. So with the Equity Council, it's made up of 17 individuals, and the majority of the council is actually from the frontline staff. So we get to listen and we get to hear. We're also Lizzie Lynch, who is not here. She's the co-chair. We were fortunate to get the SEED grant, and much of the SEED grant is spent on staff communication and working with the workforce. So there are lots of examples as to what we're doing with the workforce. I hope that answers your question, but if it doesn't, let me know.
No, it does. Thank you. And just to, I think, help us understand that we're also continuing to be involved in that and in a very integrated way. And of course, we're monitoring the workforce in a monthly report from us, but it isn't always looking at the equity issue. It was earlier in terms of trying to recruit and all. And when we get to that report, maybe we'll see whether we need a little more in-depth understanding within that. I just only wanted to commend again your response in regards to looking at disparities, and so it shouldn't only be large groups, but sometimes have to dive further down. I think there are examples. It might even be follow-up mammograms or something, and it may be within communities, and I'm just thinking of some Asian communities that it might not be a problem in one community, but it really is in another. And if we don't dive down, like you're all saying, into a more focused either ethnicity or sometimes social determinants, we may not actually focus enough to respond to the issue because we're looking at the wrong thing. So just looking at race may not be the total answer. That may tell you, okay, within that, what are the issues, right? And I think your answer saying that's the way that all of our departments are approaching this.
Yes.
Thank you.
Thank you.
I don't know if there are any other further comments, but wanted to commend this. And are we scheduled to get quarterly reports, or how often, Dr. Ehrlich, do you think that we will be able to see the progress that you're making?
We have a regular schedule of updating you on all of the True North metrics. I don't have that schedule with me, but I'm not sure it's quarterly, but it is regularly. We want to make sure that you get to hear about our work in all the strategic areas throughout the year.
Okay, well, I'll have you work with Mark, and that way then I think we can be assured that we can follow up, and at the same time, we want to be able to help support it. So
yes, and just to also remind you, what you do hear quarterly, though, is you see the scorecard. So you'll hear at a higher level on a quarterly basis what's happening in all of the strategic areas. So you will hear about that quarterly.
okay, thank you very much, and I'm glad to hear all these things tied together in different ways, which I believe is really where we have been heading for in these years. So thank you for your work in creating kind of a overall matrix upon which we're able to see all the different facets of our hospital's work. So
It's the outstanding team that does this. So I'm grateful to them.
Right. Well, if the leader didn't allow the outstanding team to do its work, it wouldn't be able to. So I think it's both ways. And thank you to your leadership and everybody who has been working so hard on not just this, but all the other issues that we get to hear. So, and
Thank you.
about that, if we have no other comments on here, then Mark, shall we call the next item, please?
Yes, Dr. Chow, I just wanted to know your sound is lower than it normally is. So if you could speak up when you're talking, I think it would help everyone understand you. You've been clear, but just kind of a low volume.
Okay, I'll try a little louder, but I do have this volume up. So
Okay.
maybe that's our connections that we were having trouble with today. So
Okay,
I will speak up higher. How's that?
that sounds great. Thank you. Item 5 is the workplace violence prevention update.
Good afternoon, Commissioners. Adrian Smith here, Chief Quality Officer. You'll see on the first slide that I have credited Andrea Turner with some of this. I will be the primary presenter of this information in this presentation. Andrea is one of the key stakeholders and owners of the A3 that we'll refer to. I wanted to credit her in the title. Next slide. When we talk about workplace violence, we immediately think of two of our True North pillars, safety and workforce, but it really affects all of the pieces of our True North. It affects equity in the way that we understand how these events occur and in an inequitable distribution among staff and patients. It affects the quality of care. It affects the care experience for patients, and it has a financial effect upon us if staff are assaulted and need time off work. So it really does address all parts of our True North values. Next slide, please. Today, we're going to look at an overview of where we came from and then give you some idea of how we plan to move forward on this. So we're going to review the current state of workplace reporting and data. And then we're also going to discuss, and I'm going to present to you what our current countermeasures are that are implemented and some planned and in progress countermeasures. Next slide. In a similar way to the last presentation, the work that I'm describing has been set out in an A3 in line with our performance improvement model here at Zsfg. So whilst we can't review all aspects of the A3 on this slide, I did want to pay homage to the fact that this work is based upon an A3. Next slide. So restating our problem statement, workplace violence continues to be a concern nationally, locally, and at Zsfg, where events take place against both patients and staff. 66% of workplace violence events against staff are concentrated in two areas. We'll address this a little more, but those areas are the ED and psychiatry, and predominantly in PES. The data that Zsfg has been collecting does not fully capture all of these events and does lack specificity. And we'll talk about how that's affected our work as we move through the presentation. Next slide, please. So our current state, we really have three top areas of focus. The first one is CPI training. And as many of you remember, CPI training is a non-violent crisis intervention training. It's a national best practice in managing difficult situations, disruptive behavior, and physical assaults. And it focuses on non-verbal and verbal de-escalation of the aggressor to try and avoid a violent event actually occurring. We also really want to focus on interventions that are going to reduce the physical assaults with harm. Workplace violence describes many types of event where there's verbal threats made, where there's physical threats made, and then where there's physical assault, sometimes without any harm to the victim and sometimes with harm. And we really want to focus on those with harm as a first line. And then we've been working with the San Francisco Sheriff's Department and other law enforcement bodies around the reduction of use in force in the clinical area. And that's in line with some national discussions that come that have been talked about all the way up to the Center for Medicare and Medicaid Services and how the healthcare environment and the law enforcement environment and how those two worlds collide sometimes in hospitals. Next slide. Zsfg has a multifaceted approach that really addresses many of these issues, and I've summarized some of them here, some of the actions and the work that we do. So we have a security leadership meeting. This is a group of leaders in the hospital led by Dr. Ehrlich, who meet with San Francisco Sheriff Department leadership. Director Price from the network is also involved in that, and we meet weekly and we review all use of force events and other issues that are focused on security in the hospital on a weekly basis. We recently formed the Assault Governance Strike Force, and this is another group that meets weekly, and we review physical assault events so that we can learn from them in close to real time, so that we can engage the leaders from those two highest risk areas that we'll talk about more in a little bit, so that we can learn how they have addressed them, and we can provide an arena for them to gain support around any of their barriers and obstacles on ways to make their areas safer. We have a monthly meeting of a workplace violence committee, and this is the place where frontline staff and leadership come together to discuss these issues. And some of the important pieces in this committee this is where we really review the progress for CPI training, and we report out on BERT, or Behavioral Emergency Response Team, utilization. And we'll talk a little bit more about the BERT team as we move through the presentation. The ED was one of the first areas to have their own department-specific ED workplace violence work group. They meet monthly and they do a department-based case review. And this is a real team approach with frontline staff, providers, and leaders in the area. I think that it really helps staff to understand that there's a focus on these events in their area. And then I also want to acknowledge that the psychiatry department has an established assault review board. So psychiatry patients, because of their inhibitions and the struggles that they have as part of their mental health process, we see that this is an area where assault happens. But that group of leaders have had a long-term process where they review each assault as it happens, and there's a lot of really great data that can come out of psychiatry that helps guide us. Next slide, please. So when we were preparing this presentation and through all of those groups that we just described, we began to think and consider where we were in this process and analyze where we're at. And we really reflected on CPI training, and we had a very ambitious plan at the beginning of 2020 to roll out CPI training very aggressively to all of the areas that needed it. And we had to revise that plan based upon the pandemic, the resources that were available, and the nature of some of the training. Some of the training is a hands-on way to learn how to escape from holds if someone is trying to physically assault you, and to de-escalate those situations. And there was a lot of thought was put into how we could safely continue to have people less than 6 feet apart learning those really important skills. So we developed a revised timeline, and that's in progress as we speak. Use of force by law enforcement is reviewed by hospital leadership, and we've already touched on this, but the focus of that is to monitor for any trends and then discuss those key events and any themes that either leadership wants to kind of add questions or learn more about, or for the San Francisco Sheriff's Department, so that they can help us to understand how they make decisions to do that. I do want to share, and this wasn't included in my presentation, but this morning we acknowledged that we had 2 weeks with no use of force reported in our weekly meeting. So I think that's really important to acknowledge that, and that the Sheriff's Department is super engaged in this process. Current data does not show trends specific to physical assaults, so further analysis is unfortunately unreliable, and we'll talk about that a little more. Next slide. We've set a target for Q4 of calendar year 2021, which is the reduction of physical workplace violence events by 10%. And this is a new goal. We had set prior goals that we weren't able to reliably say we had achieved because of the data challenges that we had had. But we still see this as one of the big focus areas for our work. So we have set ourselves a new target. Next slide. This slide doesn't tell a story, and that's why I've included it. It's confusing to me, and I'm sure it's confusing to you. It doesn't show any kind of trend, and it purely gives us a volume from July 2020 to July 2021. It doesn't tell us a story about the 46 events in July of 2021 or the 9 events in December of 2020 alone. So whilst we've been measuring volume for some time and we've been reporting out volume of events, we really acknowledge that it's not meaningful, and it doesn't aid or support the conversation in any way, shape, or form. Next slide. The current data does show us that we're still focusing on the 2 highest risk areas, and they're psychiatry, but specifically PES, and the emergency room. So these are the areas where we see the majority of the assaults occurring, and this is where we've been working with the leadership and the frontline staff in those areas to really do a deep dive on them. And this data this data just pulls out those areas. Okay, next slide. Let's think about the countermeasures that were described in the A3 that we referenced above earlier in the presentation. The focus on those high-risk areas was one of our countermeasures, and we identified that through data to be the emergency room and PES. Cpi training was another focus and another countermeasure. The way that we've addressed that is in individual areas, rather than there be master trainers that work across all areas, we took an approach where there were principal and lead trainers in each area. So some specificity to the work area and the type of patients and the type of events happening on that area could be rolled into the training being delivered. And it also helped with us in scheduling those events because they were internal to each department. And the progress of that training is reported out of the Workplace Violence Committee. I do not have those specific numbers in front of me, unfortunately, and I would have to spend a little longer trying to give you the real numbers of training. What I can share with you is in our assault governance meetings on a weekly basis, PES is moving towards being fully compliant in this training, and the ED is way ahead of other areas. Another countermeasure that was identified was increasing the behavioural emergency response team capacity in the hospital, and this was something that we were challenged by resources. Separately, we were looking at how security and the sheriffs provided those services to us in the organisation, a separate proposal was part of this year's budget, and that was around how we redesign sheriff's presence, security, and measure what the work that needs to be done was. So there are an additional more than 30 FTEs that are going to be used to address the BERT team. Of note, I do want to point out that the increase in FTEs here is achieved partly by reduction in sheriff's deputies, because we recognised that much of the work that needed to be done that sheriffs were being called for wasn't work that sheriffs were expert at. It was often to de-escalate and deal with people in crisis. So that's why that change in that methodology occurred. And then optimizing the Euro system, because our focus is safety in the workplace, and there's been a lot of great work done based upon what we know. It's also really important to acknowledge, and I think the prior presentation also acknowledged this, that without accurate, reliable data, it's hard to plan countermeasures and implement change that's truly meaningful and truly addresses the problems that we have. So as a first step, we did redesign the UO system and built a form that collects more of the data that's required. That was launched earlier this year. And the data collection and the reporting of the data to our regulatory bodies was centralized in quality management. Next slide. More recently, we began to think about what additional countermeasures we needed to address this issue in the hospital. But because it continues to be a concern for us and a concern for the frontline staff. So I have mentioned the Assault Governance Task Force. We're a group that meets weekly. Andrea Turner and myself co-chair that. And it really focuses on those high-risk areas. I want to also address two changes and countermeasures that were implemented that were directly in response to post-event issues. And we had more than one issue in PES where there was a lot of discussion from frontline staff, from leaders, and the Sheriff's Department and the hospital leadership were involved. And the countermeasure that we implemented was putting a Sheriff's Deputy in PES. And that's had a significant effect on the amount of assaults with harm that have occurred there. And it's really, I think, possibly more importantly, for the staff that work there, it's given them a sense of security and a sense that they're working in a safer environment. And then Code 50 in the ED was in direct response to the amount of violent behavior they were seeing. And what happens with Code 50 is if a patient comes in and they're exhibiting challenging behavior that's potentially or actually violent, there's a team approach. So a Code 50 is called, and a team come to the patient's bedside and they assess the patient's presentation, and they change the management of the patient in the moment. The strategies that are used are multifactorial. Sometimes it involves medication, sometimes it involves restraint, often it involves de-escalation. So this has been something that the ED have implemented, and it's had a real effect in that department. Okay, next slide, please. So let's think about our successes and achievements, and we've a lot to be proud of. Our CPI training is moving forward, and it's moving forward especially in those highest risk areas with some velocity now, and I'm proud of that. And actually, Director Price is at the Behavioural Health Centre right now delivering a class on CPI, and is able to join us to support us in this presentation because he's teaching that class there across in the BHC. We know that we're securing additional resources for the BERT team, and Kathy Ballou and her team have been working really hard on an implementation plan for this, and they have a special projects staff member who's been assigned to really project manage how we expand this service to more areas in the hospital and across more shifts in the hospital. So that's really exciting. We achieved compliance with the Cal OSHA abatement plan. We did staff and unknown complainants went to Cal OSHA, and they told Cal OSHA that they had some they had some challenges here at Zsfg, and we listened and we put together a plan, and we gained compliance with those regulations from CalOSHA, which was a huge achievement and required a lot of work from frontline staff, from leadership, and from hospital leadership. And then more recently, we included the Behavioral Health Centre into the electronic unusual occurrence system. We heard anecdotally from them that they had some challenges, and there was a perception that they may not be heard sometimes when they make complaints. So we wanted for their data to be collected and addressed and acknowledged in the same way as the rest of the hospital. So we rolled out, so the electronic unusual occurrence system used to be used by the BHC staff, and they had a change in reporting structure and they stopped using it, and we've reintroduced it there now. So and it's been received well. Staff are pleased to be included in that. Next slide. So I'm going to finish off the presentation just talking a little bit about data, and then I'll round it off by explaining why I'm talking about data. I want to acknowledge that not all workplace violence events are reported in the UO system, and that's something that we're working on, and we're encouraging staff, especially in those highest risk areas, to do so, and we continue to encourage staff to report those. I want to also acknowledge that prior data presented was all reported events. It didn't have any specificity around verbal or physical assaults. But we do want to change that, and we do want to make some data refinements. And my next slide demonstrates a couple of examples. So the first example is how we can break out physical and verbal assaults. Now, this is just 1 month's data, and it doesn't give you a trend or a longitudinal view, but it was there pictorially to demonstrate a picture more than provide a bunch of data. So the first one, separating verbal and physical assaults. That allows the risk management group to focus on physical assaults as a first priority, and within that subset, do a deeper focus on events with injury. And then secondly, our data allows us to recognize changes and other factors in the data. H44, which is our TBI unit, does have a higher rate of assault than the other inpatient units, and a more longitudinal view would show us that disparity somewhat more. You know, we're looking at what countermeasures need to be implemented specifically around those patients on H44. Some of them are the same, CPI training, reporting of events, but there are some unique pieces about those groups of patients. So understanding the lowered inhibitions in a TBI patient is super important. And also want to highlight some collaboration between Zsfg and Laguna Honda. There's a lot of work being done by Michael Phillips, the CEO over there, and by Jeff Manley here, and all of the people that support those two individuals to develop a TBI program at Laguna Honda, because what we see is some of our TBI patients stay with us a long time on H44. Placement's an issue for them. So their length of stay also impacts some of the behavior that they are unable to control that may show up in this kind of report. So there's some of the things that having better data will enable us to understand. So the last slide. So next steps overall are to sustain the countermeasures that we've described, and for risk management to work really collaboratively with the department managers to focus on ensuring that workplace violence UOs are fully completed, and then to focus on those physical assaults. This slide talks about data, but what this data will enable us to do is make Zsfg a safer place to work and to receive care. And I don't want to lose sight of that. You know, as the Chief Quality Officer, I can very easily go down a rabbit hole of being a data geek and talk about data and its, you know, how reliable it is and whether we have enough and what else we want to do. But the data drives change and drives the interventions and the countermeasures that we need to do to make Zsfg a safer place. And I just wanted to round off my presentation with that. Thank you for your time, and ask if you have any questions.
Thank you. Mark, is there any public comment?
Folks on the line, please let us know if you'd like to make comment on this item, which is item 5, by pressing *3. *3. I don't see any hands, commissioners.
Okay, so I'll look for comments from commissioners at this time. Commissioner Christian, any comments?
Yeah, I always look forward to this presentation, not only this one, but a presentation on this issue because, you know, I think we all know how important it is for us to work in an atmosphere that feels safe and supportive. And at the same time, there are, you were talking about the population that comes with certain risk factors that are just kind of inherent and need to be front of mind in order to manage. And their experience of being in the hospital as well. It's such a complicated situation. And, you know, frankly, it seems to me it's one that is, you know, you're never going to eliminate the presence of some form of violence, whether it's kind of emotional or if it gets physical, and that has an impact on people who work there and deal with it every day and who are trying to help people. So I'm always really interested in how that's going, and I'm glad to see to hear the progress that you're outlining and how you're feeling about it, that you're feeling good about it. And while I was reading the presentation in advance, I thought about what's currently being done for staff who are in this environment every day, and they're not necessarily physically harmed, but you know it's draining emotionally and harmful sometimes as well, especially when it builds up and isn't dissipated over, you know, day by day. And I wonder about that piece of it right now. I know that there are a number of things that have been going on in the hospital, and often in Dr. Ehrlich's report about staff engagement that probably address some of this. But I wonder what you're hearing from staff about that piece.
So I'll take a first stab of that, and I want to share some of the feedback that Andrea Chon, who's the nurse manager in PES, has given us about the work that's being done down in PES. So, you know, the staff in PES were feeling really uncertain and they were scared, and they shared with Andrea, who shared with the assault governance task force, that she was looking for support on how we could help her with her staff. And I think the debriefing process is super important, and Andrea has really focused on that, and I think she's one of our subject matter experts on it, and she has created a feedback loop for staff so that they feel enabled and safe to give feedback to her and any of the leaders in PES and psychiatry about how they're feeling, and to not undervalue their feelings. So I think that real time, my impression and my perception is that real time debrief after an event is super important for staff. Possibly more important than the longitudinal work and the support work that we do, because the emotions happen in the moment. And I think that's been a really powerful takeaway for me. I'm actually going to ask Andrea Turner if she has anything to add, because she's sat through many of those conversations with both the ED and PES. What else would you add to answer the commissioner's question, Andrea?
I think you're absolutely right, Adrian. What we've observed over the last few months of meeting every week is that we have strong engagement, and having the executive team as well as frontline and everyone on the same page and alignment to curing this problem, which, as Commissioner Christian mentioned, it can be traumatic. We hear from the team members as to some of the violence that they have happened to them personally, and it called us to action. I will tell you, Dr. Ehrlich has been very instrumental in this work. She actually challenged us to get this under control. And so I think for us, we've been very focused, and looking at, again, back to the data. So because some of the data is not necessarily reliable, we've had to, again, engage KPO, who has been very, very helpful, and being partners with, especially like PES, to solve some of this. And we're seeing incremental movements going into that direction. So it's actually good, but not good enough, right? So we started off where we were seeing about 5 when we started this. Yeah, we were seeing actually about 5 workplace violence, that not necessarily with injury, but it was physical. And we're now down to like 3 or 2 a week, 2 to 3 a week. So we see that some of the things that we're doing are actually moving the needle. Today, when we had our meeting, so we had our meeting today at noon, and Kathy Ballou actually spoke to this, where she said she couldn't necessarily pick one thing. She said it's a combination of the CPI training, engagement of the staff, having leadership being a part of the solution, and again, being transparent, and of course having the sheriff and trust across the board. So it's been a strong partnership, I think, and we're moving in the direction that we'd like to see it go.
Yeah, thank you, Andrea. That was really helpful. I think it's also one of the things that Andrea and I were discussing at length when we were preparing this this presentation, is that, anecdotally and perceptually, there's been a reduction in the amount of cases that have been referred to the assault governance group, as Andrea just described. But the volume of events that are reported hasn't changed. So that leads me to believe, and this is an assumption, and it's not based in science. So I'm potentially hanging myself out to dry by saying this, but my perception is that there are fewer events with harm happening, but more events are getting reported. I can't back that up with data, but based upon the amount of events that were being referred to the assault governance team at the beginning of this process to now, that's definitely my anecdotal or qualitative assessment of where we're at.
Well, I certainly hope that that's true, and also knowing that you're not devaluing those incidents that don't result in physical harm, but just making it clear to people that it's important that they report everything, and so that it can be dealt with in the proper way, and that there is and I'm very thankful for the way that the focus that you have on this, that you've described with the staff, that you're letting them know that all of this is very important and that it has an effect, and it, and you're and you're working together to address it. So thank you for this report, and thank you for the work.
Thank you. You're on mute, Commissioner Chow.
Oh, Commissioner Green, please.
Yes, well, I would echo that. Thank you so much for this work and the analysis. And I'm delighted to hear you're working with Laguna Honda on the TBI approach, which I think is so critical, because that is the area of significant focus over at LHH. So I'm really happy to hear it. And I certainly hope your assumption is true, that the events of harm are actually fewer and that the reporting is more robust. I guess there were I think 3 things I was curious about. The first is in the area of reporting. I know that some hospital systems have pretty complicated methodology to report episodes of any kind, whether it's an incident report or otherwise, that it does require quite a bit of input. And I'm curious to know whether in this process you've streamlined your reporting criteria. I also wonder if someone really is traumatized at work and another colleague would do the report. In other words, what are we doing if you feel that these things are underreported to ensure that with all of the patients and the backlog and the numbers of people that come through, that if something happens in the ED or happens in the PES, that the manpower is there to be able to give you, if not just a thumbnail sketch of what's going on, but to just put a stake in the ground and make sure that it's coming through the system at some level, so that the actual reporting isn't so complicated that it falls by the wayside.
That's such a great question, and thank you for asking that question. So I want to address it in two ways. First of all, I'm going to speak very specifically about the UO reporting system. So we built the UO reporting system workplace violence tab with some very specific data points on it, some of them required from a regulatory perspective and some of them around performance improvement. Oftentimes when we build and when unusual occurrence reporting systems are designed and built, fields are mandatory. So if you don't fill it in, you can't move forward to the next one. We chose to not make any of the fields mandatory so that in a situation where someone knew that they needed to report it, but it was hard and they were traumatized, they could give us the bare minimum information and move on and hit submit. And that's some of the next steps that we're describing, to have risk management and the department manager collaborate to fill in any missing pieces of data in it. So that was one one approach that risk management took in building the UO system, that was thoughtful around the circumstances that people were reporting. And then I think to encourage reporting, engagement of the leadership in those areas, and then working with the leadership, especially in PES and the ED, to prioritize that within their leadership teams in their areas, so that it was something that they were talking about with staff, something that was in their huddle, something that they could take back feedback from our weekly meeting to try and encourage people to report things. And we also we also talk about when cases are brought to the assault governance team, we also endeavour to crosswalk to ensure that there is a UO for those events as well, so that we can try and ensure that we're capturing as much of the data as we can. It's an imperfect science, and it is dependent upon people who are in stressful situations to take the moment to do it. But there's some of the actions and the countermeasures that we're taking by creating an environment where people feel safe to do so.
Thank you so much. I think that's so critical, and I'm so delighted to hear that that's part of it. And to what extent do you think that the staff then is aware that there is a streamlined process? Because I've seen so many people just sort of give up on incident reports, at least in my institution, because you just get hung up on some of the required steps. Indeed, you can't go to the next screen. But does the staff in all our units understand fully that this is different from what might be the case if they had to report an instrument failure or something that is more not as important as in terms of the staff experience as this?
What an insightful question, and I'm reflecting on how to answer, because I can't possibly know that all staff have received that information recently. We continue to encourage all of the venues where quality management can speak to encourage and stress the importance of UO reporting. The assault governance team, as it works with departments, tries to ensure that the leadership in each of those departments instill and disseminate that out. From a very honest perspective, I am sure there are people that don't feel confident that they can or have reported everything, because there's a real mix amongst our staff. And I think that underreporting of events like this is a national phenomenon, and I don't have all of the answers. But I hope that and truly hope that the work that we're doing in all of these different groups, from the assault governance to the workplace violence committee, and then the other groups that meet, will send that message to staff that we want to hear, and that it's super important to us, and that we, whilst we have in our True North goals that we want to be the best place to work, we really mean that, and that this is important to the work that they do, that staff feel safe here. So I hope we're sending the right message, but thank you for your very insightful question.
No, I really appreciate it. And I guess the third thing was I sent in the email uh, in January when we got the presentation about the budget and so forth. I was just confused or would love to understand better how all of the steps that, the reduction of the workforce by 21 sheriff deputies and the behavioral response teams. I think you referred to the number of people that were going to be hired on that or transferred to that. But I'm wondering how I think there were like 6 or 7 items that were presented in January overlap with this work and how, and indeed, when these things are instituted, because I know, future outcomes and data are going to be extremely important. But at what benchmarks along the way do you gather the data? Because if you gather a certain amount, but then suddenly you double the size of the BERT team, or you you put cadets in rather than deputies. In other words, I get the feeling this is a rolling plan. I'm wondering how you look at it.
Hi, Claire. Wait, I can't. It's coming in. There we go. Great. I was just asking Karen a quick question, if I can do that real quick. Yeah, sure. And then we'll get started. Yeah.
Dr. Horton, you're on. I don't know if you're aware that you're talking to us, so please mute yourself if you're not.
The central team does the CCM roles, like the LCSW and the Health Worker 3, do those fall under the Cal-AIM central team? No, I do.
I'm calling her now, everyone.
Okay. Well, while she's off the line, maybe, I think that.
So I would love to be able to answer your question with accuracy, but I'm not able to do that, and I regret that Director Price isn't here to speak to those questions more directly. And it's my understanding that at some point the commissioners will receive a more in-depth kind of analysis and update on those pieces. And I apologize that I don't have the specific answers to your questions today, Commissioner Green.
No, I really appreciate it. I'm mainly obviously concerned in understanding. I think, it was presented that Mr. Price presented, it holds such promise to make very significant and accelerated progress in this area of workplace violence and de-escalation. So I'm wondering how you juxtapose the ability to pull together these teams and make those changes to when you might benchmark progress to see, because this work is so integrated. That anytime that could be updated would be really very helpful.
What I can share is that I know that Director Price has reassured us that we won't lose before we gain, and that the implementation of reduction in force will be balanced with the hiring and the implementation of those additional resources. I can't give you specificity, and I apologise for that, but there's definitely more to come for the commissioners on these questions.
Wonderful. Well, I really appreciate it, and congratulations for what you've done to date. It's wonderful.
Thank you.
Commissioner Green, if I may, if I were to channel Director Price, I think he would say that this work is all linked together. And, it would be very hard under any circumstances to point directly to a cause and effect, either when we see, reporting going up or incidents going down. But I know that what he hopes for is that the substantial addition to the BERT team and the CPI training, which of course Adrian talked about and is part of Director Price's plan, that all of that would contribute to a reduction in workplace violence because of the strong focus on de-escalation, because that's really where we're going to make the most inroads is when we're able to de-escalate and involve all of our staff in the process of de-escalation.
Yes, totally agree, and that's why I think this holds such promise, and look forward to hearing how things evolve.
Yeah, and I would say that clearly we all have the goal in mind, and I think that as Commissioner Green was noting, it would be good that we may have a presentation that includes Director Price's viewpoint I think when he broke down data for us, I thought there had been some breakdown in the types of violence, but it may not be enough for the work that you're all doing. And so I think we need to coordinate that and try to find out where, what, how that data matches with your data, and the differences, of course, probably are more detailed to allow you to get into it. So I think that would be something that would be helpful. I was struck by the fact that PES felt that putting in a deputy really helped, and I think what this shows is, depending upon the circumstances, there were different solutions. It can't just be simply there are no law enforcement available in the ED or be a PES, but at the same time, we have to be mindful of how it also then it creates a tension with some of our patients, and that may be something that one could look at also in the future as to how one's going to balance that to make sure that staff is feeling protected, and at the same time our patients are being considered or given an environment in which they can be considering themselves to be able to be safe to receive care. So I think that could be an area that we could explore. I had a small technical question as you were presenting the Power BI and analytics, and I'm not sure what BI stands for, but I'm wondering, does this create another way of reporting UO, or is it all together? And I think, Adrian, you mentioned a tab, but is it that you go into one system, or do we have to go into a separate system in order to report workplace violence?
No, great question. Thank you, Commissioner Chow. The reporting is all in one system, the UO system. If a front end user needs to report a medication event, a slip and a fall, or a workplace violence event, it's all reported in the same place using the same system. The Power BI is, we will export the data into Power BI, and it's really it's a way of us being able to slice and dice the data more effectively, and it's going to give us the ability to begin to measure things like rate instead of volume, so we can relate the amount of events per patient days or patient encounters, depending on the area of the hospital it's in, break it out by race and ethnicity or other defining factors, and allow us to analyze the data. It's just a tool. It doesn't change how the data is reported, and that's all in one place.
Oh, great! That's a great help, and I think it is very important that we are getting a much more in-depth report on how we are managing or trying to understand and work in regards to workforce violence. So we'll look forward to your future reports. If there are no other comments from anybody.
Dr. I'm not sure. Commissioner Green, is your hand up from before? Or okay, I'm sorry. So I will erase that. I apologize, Dr. Chow.
Okay, no. Please, you have to keep keep a sharp eye on that, because I don't see everybody's hands here. So really appreciate that, Mark. Should we go on to the next item then, Mark?
Yes, sir. Item 6 is the Zsfg CEO report, emergency department newsletter, and nursing newsletter.
Good evening again, commissioners. Given the time, I will be brief. There's a lot in this report, and of course, I'm happy to entertain any questions at all. In the first section, I really tried to summarize all that's happened since the last time we reported to you a month ago. And it becomes increasingly challenging to do that because there are so many changes. And I think we were talking about the workplace and how our staff feel and how people feel. And I can say, this last fourth surge has been really challenging because in some ways it came as a surprise. It's been hard to sort of wrap our minds around how we need to respond the same and differently in this surge. So we did enter our fourth surge in July, you know, we have been responding in a lot of different ways, especially initially there was a new masking mandate. Recall we had all taken off our masks, and then there was a health order requiring masks to be worn inside. That didn't affect our environment as much because we continued to wear masks inside, but that certainly affected the rest of people's lives. We also expanded testing as testing, the need to test became more urgent. So we did that. We expanded the hours where we were testing. We also, in accordance with the state health order, we updated our visitation guidelines. And this required us to become more restrictive with our guidelines, namely to require proof of vaccination status or a negative COVID test within the previous 72 hours. There was initially only an exception made for end-of-life care, then quickly maternity care and pediatric care was added, which was great. We also, in an attempt to best serve our population, even though we didn't need to, implemented a point of care testing for people who were unable to show proof of testing. We also relocated our patient vaccination clinic. We had, as you recall, moved it into the wellness center because the demand for, vaccination center. We had moved it into wellness because the demand for vaccinations had come down. Once we started offering supplemental mRNA vaccinations for people who had received the J&J shot, our volume increased quite significantly. So we moved it back into the learning center where it is now. And that also has enabled us to meet the additional demand that we anticipate for providing booster shots for immunocompromised people. So an incredible amount of change over this past month. And I really want to commend all of our staff and all of our teams for addressing these significant changes. There will be more to report to you next month, but that's what we have here. The second item is the Joint Commission Revisit Survey, and I had the great privilege of being present for that exit survey, and it was really quite a highlight. And I wanted to say just one other thing that she said that was so great, which was that she can see, with her experience as a surveyor, she can see when staff are just performing for the surveyor. And she said she really saw evidence of deep commitment to improvement amongst our team. And she saw incredible teamwork, especially, for example, in this case, how the SPD staff worked with the clinic staff to improve the way we handled instruments. So it was just, it was lovely. So you can continue to read about it in this item here. Let me move on. I did want to just point out Jim Marks' Day. He cannot be celebrated enough for his contribution to the pandemic. So July 20th of 2021 was Jim Marks' Day, and it's commented on in the narrative. I'll move into the data now. You can see COVID positive patients. This timeline you can see highlights the four surges now very well. Today we had 20 COVID positive patients in the hospital. So we've definitely seen an increase, but it hasn't gone up anywhere near as high as it did during the third surge. And hopefully that continues, given that the cases have started to level off in the city as well. Emergency department volume, you can see, is slowly going up. What is going up even more sharply is our ambulance diversion rate. And I know, Commissioner Green, you had a question about this. Unlike in previous times, the reason that diversion is so high right now is almost entirely because of staffing. Staffing, as you know, staffing hospitals is a national problem. It's actually a crisis throughout the United States, and it is not. It is challenging here as well. So what happens is we only have the staff, the nursing staff specifically, to open so many emergency department beds. And once the emergency department fills, then we need to go on ambulance diversion. At the last meeting, I think you recall, we spoke about this pretty extensively, and I feel confident that our work with HR, we are filling nursing vacancies as quickly as we can, given the circumstances. So for example, we were able to get some registry staff. They started this week. We have hiring that's going on. We have a training program in the emergency department that has started. So I think given the circumstances, we're doing as best we can, but the diversion really is entirely because of staffing at this point. You also, and you can see that, you know, urgent care encounters are going up along with the emergency department encounters. This is just a reflection of the demand and the people coming into the hospital. That system is working really well. We continue to have regulatory flexibility that allows us to sort people more efficiently than we have in the past, and that is working well. PES encounters, you also had a question about. This is a function of the fact that we can't move people out of the inpatient setting. We have people especially waiting very long periods of time for certain types of care, mostly locked psychiatric placements, less so in numbers, Napa State Hospital and Psych SNF, but especially for Napa Hospital, our patients are waiting 18 months, I think, on average for those beds. So even one patient takes up a bed for a very, very long time. So that's what's happening in PES. I really want to commend the emergency department and PES for managing the volume of patients between those two areas. They've done a remarkable job under really challenging circumstances. And they've been working together, which is really great. I think I will stop at that point unless you have other questions. The workplace violence, we've just had a very extensive and wonderful presentation on that, so I don't need to cover that. And the salary variance data is the same as we've seen previously. So I'll stop there and see what questions you have. I want to really commend our team, especially at this time, for just being so resilient and remarkable in the way that they provide care to our patients.
Mark, are there any public comments on the report from Dr. Early?
Sure. Folks on the line, if you'd like to make a comment on item 6, the CEO report, please press *3. *3. I'll give you a few extra seconds to make sure you've got time to do that. I don't see any hands, commissioners.
Thank you. Commissioners, any questions? I just want to note how extensive the report is, and the data is really quite clear. And I'll see if I think one question that I know Commissioner Green did have, and I was hoping to also hear the answer to, was the left before being seen numbers seem to be going up. And then if I add also the average daily transfers from the ED to the urgent center is up, continues up, but that's okay, understandable from your discussions. But likewise, though, the daily transfers from the urgent center over to the ED have remained at a fairly high level. So I know we talked about that last month a little bit, but I was wondering if you have further insight into that. So those two were questions I did have.
Right. Well, going back to leave without being seen, that is obviously a number that we don't want to see going up. It had gone down quite a bit as we saw volumes drop in the ED earlier in the year. We're aiming for 2% or less. That's the national standard there. And so we do everything we can to see people at the right place, time, and with the right service. When we do that, we know that the rate of leave without being seen goes down, being seen or triaged. So the movement between the emergency department and urgent care, I view that as a good thing. As long as our volumes are going up, and they're up almost, but not quite, to normal levels, we really do want to see patients being sorted to the correct level of care. So having patients move from the ED to urgent care and vice versa just reflects that the staff are doing a great job moving patients to the place they need to be seen for the care they need at that moment in time. What we wouldn't want to see is if, for example, somebody was, if the emergency department sent a patient to urgent care and then urgent care sent the patient back again. But we know that doesn't happen. It's more that they're trying to make sure that the patient sees the patient in the right space in the right time initially.
Okay, thank you. Commissioners, any other questions on the CEO's report? Do you see any other hands up?
I do not see hands, Commissioner.
Okay, well, thank you again for bringing us all up to date. And the reports from the nursing newsletter and the ER newsletter, I must say, do help us understand these departments also and the work that they're all doing. So that has been also very helpful. So really appreciate that.
They do a great job.
Okay, so, oh, I did have one question because I've been asked this. People who are immunocompromised right now are having some trouble finding a site. Matter of fact, one person actually belongs to UCSF, and the UCSF doctor apparently told him he needed to get his third shot, but he didn't know where. And so if UCSF physicians didn't know where, I was wondering, is the unit here open only to the San Francisco Health Net patients, or is this really available, and is it by appointment or a drop-in? And are we getting the information out for our public then as to where they're supposed to get this third shot? Even on orders of doctors, doctors don't seem to know.
Well, I hope that's not one of our UCSF physicians, because we're sending them quite a lot of information. I'm just seeing if Dr. Day is on the, is present, because, oh, good. I'll let you answer the question. Thank you.
Hello, Commissioner. Sorry, I'm having some internet issues. So that's a great question. We at Zsfg are open up to the entire community. So our patients, any San Francisco residents, or anyone who received their vaccine here, we've distributed that information out via sort of multiple outlets, so social media, on the website, and through the news. The other thing that's been also, I think, very helpful in this is that anyone can go to their local pharmacy. So CVS or Walgreens have ample supplies, and they just have to self-attest that they are actually immunocompromised and can get their vaccine for free there too. At the pharmacy, no appointments are necessary. At Zsfg, we do require appointments, but sometimes we also will allow drop-ins, and we're Monday through Saturday.
Very good. I'm aware of this one case is a UCFS, not from San Francisco County, from the other campuses. So I don't know if the word has gotten out to them, or perhaps just to make sure that the UCSF campuses know how to administer these, because I'm sure they have a almost probably disproportionate number of immunocompromised people in the city here.
Yeah, that's a great point. I believe they have 2 offsite campuses for their outpatients to drop into. They sent a memo out last Friday that they were going to start this week at some point.
Oh, okay. Maybe across the memos. Really appreciate that, and it's I'm sure going to be a continued challenge as we go into potentially go into the recommended third shot. So I am appreciative of the report. Commissioners, any other comments, or we will then move on to our next item, Mark?
Sure. Item 7 is the hiring and vacancy report.
Thank you, Mark. Good afternoon, Commissioners. For the HR report out, we increased the overall vacancy rate to 8.95% as of July 31st. We did hire 25, and we had 13 separations. The RN vacancy rate increased to 6%. As noted on the report, we're facing similar challenges to previous months in regards to recruitment and decreased applicant pools. To mitigate those challenges, we're hiring temp non-benefited P103 nurses to fill in the gaps. We're increasing our merit analysts to refresh eligible lists more frequently to capture newly applied nurses. and we're partnering with the nursing leadership in streamlining our selection process. New information since this report summary was written is the upcoming creation of an all DPH RN team that will exclusively focus on nurse hiring 2320 and P103s. This team will continue the expedited nurse hiring that we did last year and report directly to Karen Hill. Next month, at the report out, Karen will provide more details on this new team. Commissioner Green asked about the implication of returning the hiring to the managers. We don't anticipate any negative impact. The positive impact is allowing our recruiters to focus on candidate sourcing instead of selection of candidates and filling positions. However, there's still the option for HR to continue to assist with selection per the manager request. Are there any questions?
I think we're all very pleased to hear about the all department-wide effort on recruitment of our nurses. So that just seemed like a very good development that I'm sure we're going to appreciate a follow-up on.
Will do.
Is there any public comment on this item?
Folks on the line, if you'd like to make comment around about item 7, which is the Zsfg hiring and vacancy report, please press *3. *3. No hands, commissioners.
Okay, and so I see Commissioner Green has a question.
Yeah, well, I just wanted to compliment you on the effort you're making and on the thought that's gone into it. You know it's a crisis in nursing when every member of the medical staff at CPMC got a letter from the COO and the CEO basically describing how difficult it is, how there are no travelers. It is incredibly difficult to hire nurses. And of course, this is even when COVID is at a lower ebb right now. And so, I so respect what you're doing, and I feel like you're getting out ahead of the competition because it really does seem dire. And in my entire career, I've never gotten a communication like this, and we're all feeling it on our units without question. And the other correlate, I guess, to this that I know you're excellent at is the concern obviously about burnout, which is a problem with the COVID stress as it is, but I know a lot of people are working extra shifts and overtime, at least in our institution, and I see them every day, and it really troubles me and worries me that we need to do more to try to support. And I know you guys wrote the book, so I'm not as concerned, but I do see daily the kind of stress that staff, and not just nursing, but across the board face in response to the shortages. So I know you also have a very concerted and thoughtful plan in that regard, but it is every day palpable in my world. So I'm really grateful to what you're doing here.
Thank you, Commissioner Green.
Commissioner Christian, did you have any comments on this? I can't actually see, but I don't want to ignore you. No. Okay, thank you, and you're on mute. Okay, but I got that. Thank you. Okay, Mark, let's go on to our next item then.
Item 8 is the medical staff report.
Hello, commissioners. I am very pleased to present the medical staff report to you this afternoon. So our first item is that the Department of Obstetrics, Gynecology, and Reproductive Sciences presented their service report at MEC. It was really a beautiful report, and I will just highlight 3 areas in the interest of time. So one is that Dr. Jackson highlighted their independent midwifery service, which is really quite unique, and how this really affects the culture of the whole department in a positive manner, including really leading to a very low rate of cesarean section across the board, not just for those patients who are primarily cared for by the midwives. Dr. Jackson also highlighted the progress they've made with telemedicine, spurred on, not surprisingly, by COVID. And then she also highlighted the very impressive anti-racism work that has been a focus of the department for some time. And they are really trying to move that forward very consistently. So Dr. Green had 4 really fantastic questions related to the OBGYN report and their rules and regulations. Dr. Jackson was particularly pleased by your questions, Dr. Green. She said they reflected somebody who obviously was very expert and had taken a lot of time to read it. So I hope I will do justice to Dr. Jackson's answers to your questions. But regarding the issue of UCSF's backlog in prenatal care appointments, and can San Francisco General partner with them? So San Francisco General is actually working really hard on this, although some of the efforts have been hampered by an unfortunate sometimes negative perception by patients in UCSF alike about what it might mean to get care at San Francisco General. But there are a number of things that are in progress, including that there is a contract through Canopy that patients can get their prenatal care at UCSF, but actually have their delivery at San Francisco General. And that has been very promising. And there are also, the department here is orienting their staff to the hospital, the outcomes here, and promoting the availability to any patients with Medi-Cal. And so that is something that is actively and I think effectively in the works. I think the second question was regarding the quality parameters and how these apply to the outpatient setting, particularly for the Black African American community, and any efforts, particularly around continuity of care. And Dr. Jackson highlighted a project that the department is undertaking actually in conjunction with medical students, looking at the barriers and solutions to having continuity for the postpartum visit. And one of the departmental midwives has actually started a group perinatal care model for Black African American patients, which so far is going very well. They're also piloting in several clinics a continuity model with having the attending as the provider of record rather than the resident, so that even if the residents switch rotations, that the patients will have continuity with the attending. So those efforts are underway. And then I think there were 2 questions about, because we'll talk about in a minute, the updated rules and regulations, which include the OBGYN privileges. And so there was a question about fistula repair, which really is more of a specialty procedure than a general procedure. And you are correct that people select which privileges are most appropriate to their skill set. And Dr. Jackson said that the urogynecologists and gyne-onc physicians do those procedures, but they're actually not requested or done by the generalists. And then I think you also had a question specifically about e-sure placement, and just noting that it is not a permitted procedure, that it was banned. And Dr. Jackson said, yes, that of course that is the case. And they stopped placing them as soon as that change came into being. And it will be in the next update of the privileges that'll be removed.
Please convey my thanks to her for those extensive answers. And I am so impressed by everything that's done in the OBGYN department of the county. I think these things are incredibly innovative. They're our go-to center for advanced terminations, which is desperately needed across the country and certainly here. And I think everything they're doing is very thoughtful and I think will definitely improve outcomes, especially for many of our underserved populations. So I was very impressed by the report.
Happy to take other questions or comments if there are any.
I just wanted to comment on kind of building on what Commissioner Green just said. The very last point on this report under goals for 2020-2021, prepare for post-Roe era and respond to the need for abortion services. It is gut-wrenching, but just so kind of emblematic of the way that this institution and the people who work in it and run it, how they think. The fact that that is, that you're going to be prepared for that, you're preparing for that right now, is very good to know, and it is again just emblematic of the strategic thinking and the care that you have for the community. So thank you for that.
Thank you. I do not believe that we have any other comments. Thank you very much for the extensive report from OBGYN. And I would echo Commissioner Christian's comments. I was surprised to see that we were thinking in this manner and being prepared for all circumstances to be able to care for our residents here. So thank you. Shall we go on to your next item for action? Or, well, I guess, did I already ask for public comment?
No, I was going to say, if I could quickly ask before we move on to the action. Folks on the line, if you'd like to make comment on the report for item 8, I believe it's item 8, please press *3. Okay, no hands. Thank you. Go ahead, Dr. Winston.
Oh, thank you very much. So yes, the requested action item is for the OBGYN rules and regulations that they updated in conjunction with their clinical service report. I believe you have a copy of those, including a summary of the changes. I think the changes are all relatively minor, but happy to take questions about any of the proposed changes.
So commissioners, do we have any questions on the changes? If not, a motion to accept these changes are in order.
Move to approve.
And,
Second.
I'll do a roll call vote.
Thank you.
Yes, Commissioner Green,
Yes.
Commissioner Christian,
Yes.
and Commissioner Chow.
Yes.
The item passes. Thank you. Shall we go on to the next item, Commissioner? Thank you, Dr. Winston.
Yes, please.
Sure. Item 9 is other business. I'll go ahead and ask for public comment for this item. Please press *2 if you'd like to make a comment for other business. No hands, and I also don't see hands from commissioners.
Okay, so let's go on to the next item then.
Sure. Item 10 is general public comment. Folks on the line, this would mean making comment about something that's not on the agenda, a topic that's not listed on the agenda. Press *3. No hands, commissioners.
Okay, so next would be entertaining a motion for closed session.
Move to closed session.
I second the motion.
I'll do a roll call vote. Commissioner Green,
Yes.
Commissioner Christian,
Yes.
and Commissioner Chow.
Yes.
All right. Thank you, everyone in the meeting who is not going to be joining us in closed session. I believe not everybody should be coming over, so I'll let you self-select. And folks in the comment line, we will be back in open session. It will take a while, but if you'd like to wait, you can. I'm going to switch everybody over, so give us 30 seconds. Okay, we are back into open session. Commissioners, please consider a motion to not disclose discussions held in closed session.
So
Move not to disclose.
in order, I hear yes. And is there a second?
Second.
The roll call vote, Commissioner Green,
Yes.
Commissioner Christian,
Yes.
and Commissioner Chow.
Yes.
All right, I believe you are now at a possible consideration for adjournment. Motion for Tuesday.
I want to be clear on the previous vote that we called for non-disclosure. Is that clear? Mark? Okay, good.
And it'll be noted in the minutes as well, sir.
Okay, thank you. A motion for adjournments in order.
I move that we adjourn tonight's meeting.
Second.
Roll call vote, Commissioner Christian,
Yes.
Commissioner Green,
Yes.
and Commissioner Chow.
Yes.
Thank you, everyone.
Okay, thank you, everybody.
Thank you, Mark.
Okay.